Hello, welcome back to King's podcast. This is the Wellness Dive with 𝘸𝘫𝘬. I'm your host, 𝘸𝘪𝘵. The word migraine gets thrown around a lot, but how do you know that you have a migraine and not a headache? Today we are joined by Dr. Olusegun John Oluwole, neurologist at King's College Hospital, London and Dubai, who will be taking us on a deep dive into migraines. Welcome, Dr. John.
Thank you so much for having me.
So, what's a migraine?
What I like to say about migraine is it's an inherent tendency to have recurrent headaches without an underlying brain disease. So such individuals, when you scan their brains, looking at it structurally, everything is normal. You don't see any evidence of disease, yet they have recurrent headaches. So it's an inherent tendency. We think the root lies in the genes.
And then, like I've mentioned, the word migraine gets thrown around a lot. Somebody might be having a headache, and then the first thing that comes to mind is, oh, I have a migraine. I have a really bad migraine. What's the difference between a migraine and a headache?
Right, I get asked this question a lot of times. A headache is a symptom of migraine, even though a lot of people use the word migraine for certain types of headaches. But those are the types of headaches that typify migraine. So like I said before, the migraine is like an inherent susceptibility to headaches of certain kinds. So these individuals' brains are wired in such a way that they're very prone to headaches. The headache of migraine is of a certain type, usually. Most of the time, we talk about a headache on one side of the head. There's usually throbbing. Some patients describe it as, pulsing or pounding, and it tends to be moderate to severe. It's usually not so mild. It gets worse with noise. It gets worse with exposure to light. Sometimes the patients throw up. Sometimes the patients are dizzy in the process. So that's the typical headache of migraine. However, someone who's got migraine can have other types of headaches. So those who've got migraine would have different kinds of headaches at different times, but at least at some point, they would have the typical headache of migraine. So some of them are able to identify this typical headache and they call it migraine. So they will tell you, I had 5 migraines last month and I had 6 headaches. So trying to tease out those headaches that look typical of migraine and other ones that are not so typical. But patients with migraine have all sorts of headaches. So the migraine is much more than the headaches. There's so much in it. But the baseline is there's that vulnerability to headaches, and then they keep having headaches. So that's the thing. But then there are a few other things like light sensitivity, sound sensitivity, and all of that. So someone who's got migraines necessarily has to have headaches. So migraine is not exactly the same as headache, but headache is a key component of migraine.
So would I be right in saying that migraine is a type of a headache?
In a sense, you can say that. So we have different kinds of headaches in the broader scheme of things. So there are people who've got frequent headaches, yet they don't have migraine. So it might be another kind of headache. That's like a cluster headache. We have tension type. So in classifying what kind of headache people have, then we can say some people who have headaches do not have migraines. Some people who've got headaches have migraines. And again, those who've got migraine, they may have typical migraine headaches, and they may also have other kinds of headaches, that are not so typical. So that's the thing. So it's a bit of a technical thing. So, but the baseline is there is headache involved, basically.
It sounds a bit confusing, trying to differentiate between a headache and a migraine. So to make it clear, what are the common signs and symptoms of a migraine?
Okay, so
and how can you differentiate?
So sorry if I've made it a bit confusing. So the idea is, say, someone who's got migraine is very common, by the way. It's extremely common. If you gather 5 women, at least one of them would have a migraine. So it's that common.
Why women?
Why? It's much more common in women than men. Usually before puberty, it used to be about the same. But then, or it will be the same, but then after puberty, then it starts to separate. Women tend to have more. I think there's some rule for hormonal factors. Okay, so the female hormones probably, help migraine to fester a bit. In trying to talk about the cardinal things, so first of all, someone who's got migraine would have recurring headaches with no explanations. And then number 2 is at least some of the headaches would usually be one-sided, would usually throb or pound. There would usually be nausea or feeling sick. There will usually be some sort of dizziness, light sensitivity. Such individuals, when they're having headaches, they don't want to stay in a very bright environment. They want to avoid it, or it might be sound sensitive. So if someone who's got recurrent headaches has some of these features, then that helps us to define migraine. So their own type of headache, then we say migraine is the cause of their recurrent headaches. But there will be days when they would have other forms of headaches that are not so typical. They might just tell you they've got a headache behind the back of their head, which feels like pressure. But you already know that these individuals, you've diagnosed them in the past that they've got migraine. Some of their headaches in the past have got those features of migraine. Even if what they're describing as at the time they're talking to you does not fit into the picture of migraine, but there have been headaches in the past that fit into that picture, then they still have migraine. So that's still the classification of their headache. So migraine can be seen as a diagnosis, okay, which would be the cause of people's headaches. And then migraine can be seen as a subtype of headache. So, you know.
Okay, you've taken away the confusion. We understand you loud and clear.
All right, thank you.
So other than, since you've taken away the confusion, at what point should one come to see a doctor, and specifically a neurologist, for the headache? I mean, yes, I can pop a Panadol or two and I would feel better. I would not feel better, but then after 2 days, I'd feel better. At what point should I come see you?
Okay, so I would say if the headaches are lasting for so long, like you said, for 2 days in a row, and that's already impacting daily activities, you can't function, you're missing essential, parts of your day, you can't function for a given period of time, you can attend social events, you can go to school, certainly you need help, so you would need to see a doctor. You're getting to have too many headaches in a week or in a month, then that would warrant seeing someone who knows about headaches, perhaps a neurologist or a headache specialist. Those would be important. Or there are some people who have their migraine attacks associated with weakness on one side of the body. I didn't talk about that earlier. That migraine again is a very heterogeneous syndrome. So you might have some people having weakness on one side of the body with their headaches, or numbness on one side.
Oh, so that happens.
Yeah,
that can be confused with a stroke.
Yes, it can be confused with a stroke. So I remember I've treated a lady who had a migraine attack that lasted for several days, and then came with weakness that also lasted for almost 7 days before the weakness resolved. So that can happen. So such individuals would certainly need to see a specialist to help them with their headaches. So it depends on the impact. So we assess. So not every headache patient is the same, or not every migraine patient is the same. So it depends on the amount of impact it's having on their lives. So if it's having a lot of impact, then you certainly need to be helped. And then the other thing is it's always important to see a neurologist or headache specialist at some point to help to establish the diagnosis, because you can't just assume that it's migraine. There are so many mimics of migraine, so it's always important to see a neurologist or someone who knows about headaches to help confirm the diagnosis, and then subsequently management. Of course, the patient would have to play a major role in the long term, but at least at one point or the other, it's important to see a neurologist to be sure that truly the headaches you've been having are due to migraine and not something else sinister. Because if you recall at the beginning, I mentioned that in migraine, typically there is no underlying brain disease. So a neurologist needs to have seen, or someone who knows about headache needs to have seen and established that truly there's no underlying brain disease and this is purely migraine, and then you can now plan your care. But the long-term care will still be by the patient. So, but then the guidance needs to be by the doctor.
Okay. Before we move on, so I'm gonna ask you, how bad can a migraine get? Because we know there are people out there who don't like seeing specialists or doctors of any kind, and in this case, I'm talking about men. They are really not good at seeing doctors. So, how bad can it get if one doesn't see a specialist for that?
It's very similar to what I said before, that no two migraine patients are the same. I've got patients now who have headaches every single day. And some people even have non-stop headaches, like for a whole month, the headache just lingers and then fluctuates from time to time, but there is always headache in the background. So such kind of individuals have got a very major impact on their life. They can't even function. I remember consulting with someone just over the weekend, and the person was like, I'm not myself. I can't study. I mean, she's actually doing her PhD. She can't study. She can't function at home. She can't do anything, basically. So she's got headache, all the time. So that tells you how bad it can get. So the point is, if people are getting very frequent headaches, migraine can transform into, perhaps I should lay this foundation first, that again, migraine can have two kinds. You can have episodic, based on, how frequently people have headaches. So it can be episodic, it can be chronic. So when you talk about episodic migraine, those are the kind of cases in which you have a distinct headache attack that starts and finishes. And you have a period when you are headache free, okay? And then the number of days that you have headaches is less than 15 days a month. So, but then when you get to the chronic form, then the headache transforms and becomes more frequent. They start to have more headaches, like on alternate days or so. And then in the months, you might have up to 15 headache days. So when people are beginning to transition into that phase, then things start to get more and more difficult. So a doctor needs to step in at this point. Otherwise, they might get to the point of becoming, refractory. We've got cases of refractory migraine in which you throw in everything to help them, yet you're not able to stop their headache. So I've got people who've got headaches, refractory headaches for almost 3 years, and they've taken every medication on board, yet nothing works. So stepping in at the right time with the right intervention is extremely important to prevent people getting to that phase of chronification.
Okay, Dr. John, you mentioned that somebody can suffer from these headaches stroke migraines for more than 3 years. I'll give you a scenario. Let's say patient X has been having headaches for as long as she can remember. Each and every doctor, by this I mean GP, neurologist, they can't find anything wrong with that. But currently in her, let's say, mid-40s, they're getting worse, saying she's getting high blood pressure, low blood pressure, and whatnot. How can that be solved? I mean, diagnostic-wise, how do you diagnose migraines?
Okay, it's always very important to separate primary headaches from secondary headaches. So when we say primary headaches, migraine is one of them. It's perhaps one of the commonest primary headaches for which primary types of headaches for which patients come to the hospital. So a primary headache is a headache in which there's no underlying abnormality, there's no underlying disease that is causing the headache other than a headache itself. For example, migraine is a primary headache. Okay. So there are secondary causes of headaches. So there are so many of them. So in such cases in which you mentioned this individual having fluctuations in blood pressure.
Yeah, exactly, for years.
Yeah. So it will be important to see a neurologist. So the first thing is we want to see to be sure that there's no hidden cause for this headache that has been missed over the years. So for example, I have seen some patients have what they call low Csf pressure headaches. So,
what is that? To normal people like
right. So to bother by the medical term, I'll simplify it. So the brain is in the skull, like we all know. But then if you move your head, you don't feel your brain hitting against the inside of the skull. So it's because the brain is suspended and surrounded by water. So it's basically swimming there.
Yeah.
So it's well supported. So in some people, the volume of that fluid or water that suspends or surrounds or bathes the brain is reduced for some reason. And the pressure is low. So the buoyancy of that water is reduced. So the brain sags, kind of. So in such individuals, they might have headaches that mimic migraine. And then some of the clues to that will be, some of them initially at the beginning, several years back, they might have experienced a situation where standing made their headaches worse and then lying down made it better. But then over time, if that's missed, over time, then that ceases to be the case. They continue to have headaches all the time, and that can mimic migraine. And there's so many other things that doctors would have to look into. So I would suggest that individual needs to see a neurologist and then would try to take the history. If it's been going on for so many years and it becomes a bit more complex, you need a doctor who is patient enough to take the history, stepwisely, and then exclude all of the things that need to be excluded, and then carefully reach a diagnosis. And then if nothing else is found as a secondary cause, if you're settling for migraine as the cause, they will not have to look at the potential options that can help to improve this individual's chronic migraine now, I would say, or even chronic refractory migraine, CRM, so to speak. And there's so many others, a few things, a lot of things that can be done to help such individuals. And then there may be also some barriers, unidentified barriers to improvement that need to be identified. Does the patient have depression, for example? Does the person suffer from anxiety, for example? There might be some other unidentified problems that need to be, carefully looked for and then targeted so that this individual can improve.
All right, doctor. So still on diagnostics, what are the modalities you use to diagnose the migraines or whatever is behind it?
Right. So usually the most important thing we want to do in the clinic is to exclude secondary headaches. Somebody has come with a headache. The first thing is to listen to the story. The first 5 minutes, we let the patient speak uninterrupted and describe their headaches well. And then if it fits into the profile of what we call migraine, then we now begin to ask specific questions to look for underlying secondary causes of headaches. So, and if none of those is present, then we're more comfortable to say this is likely to be migraine. And then some of these individuals might have family history as well of migraine. To look for telltale signs of secondary headaches. And then sometimes some of those patients would meet the indication for some kind of tests, maybe some head scans also. And then we do that. We don't scan all all patients, so we don't scan all of them. There are occasional patients, perhaps 10% of patients, who would need a scan or some of that kind of tests to exclude a secondary cause. But once you're sure you have confidently and comprehensively reviewed the patient and done all the things that you need to do to exclude secondary causes, then you can make a firm diagnosis of migraine, and then you move to the stage of treatment. So the first step usually is to exclude a secondary cause.
I'm going to ask you this. What's the worst that can happen if a migraine is not detected early enough and the correct form of therapy introduced for the patient?
Honestly, there's an immense amount of suffering that people can go through from migraine. People can lose hours, days, weeks, of their lives to pain and not being able to function adequately. So there are people who can't do things that they are supposed to do because of that. So basically, it's going to be in terms of hours lost, days lost. And of course, this translates into productivity, translates into loss of income as well. And then some of those people, they don't go to the right doctors, they keep going to the hospital. So, keep moving from hospital to hospital. So it has a lot of things involved. I'm sure it will surprise you that the oldest person I've seen with migraine so far is a 70-year-old woman.
Oh.
And she's got migraine for almost 40 years.
Oh.
And she was never given a diagnosis of migraine. And then we diagnosed her for the first time just a couple of months back, and then started her on some treatment. So people's lives can even still improve at 70. People's lives can change even at 70.
Yeah. There's still time.
Right.
So talking of migraine treatment, so from what I understand, feel free to prove me wrong. Migraines don't have a cure, but they can be managed. How true is that? And what do you do to treat / manage them?
And that's absolutely correct. That's correct. So we can't cure migraine because it's an inherent tendency. So you can't remove that tendency. So that individual who's got migraine is genetically prone to having headaches. So you can't remove that. However, you can do a lot to make their lives comfortable. So what we look at is to look at the overall burden of the headache. So there are forms or questionnaires that we can use in the clinic to quickly assess the burden that this headache is having on the individual. So sometimes we look at a diary and we see how many headaches they're getting. And when they have those headaches, how long do they last? What impact is it having? Some are missing schools, missing work, and all of that. There are a lot of interventions that can be put in place in terms of, it starts with lifestyle changes.
What kind of lifestyle changes?
Okay.
When somebody talks about lifestyle changes, you're like, okay, I can lose weight. What else can I do?
Right. Losing weight is one of it. This is one of them. It's extremely important. So having a healthy weight, that's very useful in migraine. So we know that overweight is a risk factor for worsening of headaches. So it's one of those things we push, especially for those with refractory headaches. So we'll start from there. So thank you for mentioning that. What I say, generally speaking, is to be smart about your migraine. So S has to do with sleep. So I say this to my patients that there is no migraine without sleep. If your sleep improves, if you sleep well, you have a good quality of sleep, your migraine is certainly going to improve. So if you sleep very poorly, then your migraine is certainly going to get worse. Consistency, okay, and sufficiency. So you need to sleep sufficiently. And an adult would need at least about 7 hours of sleep in a day, in the night. And then, of course, the time you start to sleep is also important. So you don't say, okay, I've gone to bed at 2 a.m. and then I sleep from 2 to 9 a.m. and then that's 7 hours, but that's not good enough because that's stressful. Say if you've got migraines, you need to go to bed before 12 midnight. Say anything later than that is going to be perceived as stressful to the body, and that can make your headaches worse. So sleep is extremely important.
And from what I've seen, from my own experience, it's really difficult for somebody who's suffering from migraines to fall asleep. How can they induce sleep if they are really unable to fall asleep because of the migraine?
Got your point. So sometimes it's a vicious cycle.
Yeah.
So you have a headache, they're stopping you from sleeping, and then you're not sleeping, and that makes your headache worse. So it's
exactly. Yeah.
So what I tell such patients is we just have to break the cycle. So we target both of them. So we try to break the cycle of a headache. We try to give, the right therapy to stop or reduce that headache. And at the same time, we may also give some sleep aids, over a short period of time so that when the individual sleeps well, the headache is going to improve. As the headache improves, sleep improves. That's very important.
Okay.
So
great.
thanks for raising that point. It's really important.
Okay.
And the second thing is the M. I talk about being smart about your migraine. So the letter M stands for meals. So, some people are so committed to their work or wherever they do that they don't have time to eat. And that includes myself. So it's important for people to not skip meals. They need to have regular meals, and they may even snack in between. So at least 3, square meals, and then in between there could be snacks to make sure they don't get hungry, because hunger can be a trigger for migraines, okay? And then, of course, thinking about coffee, for example. So coffee is like a double-edged sword, actually. Yeah. Sometimes it helps relieve migraine headaches, so it can be therapeutic. But then if taken in excess, you're taking 4 cups, 5 cups of coffee a day, then that can be harmful, because in the longer run, when you are unable to maintain that, then you may have withdrawal headache. So usually what I say is moderation, perhaps no more than 2 or so in a day. And then you need to factor in the next point, and that has to do with hydration, still with meals. So if you're taking a lot of coffee dehydrates you basically. So you need to take a lot of water. And I tell every migraine patient that they need to drink at least 2 to 3 liters of water every day. So that's extremely important.
Wow.
So, and if you drink a lot of coffee, then you need to drink even more.
More water.
And I've got a patient, for example, whom I told to start drinking a lot of water. And that's the only change they've made, and that's improved their headaches a lot. They're not even taking medications at all. They're just taking a lot of water.
Yeah. That's good.
And then the A stands for activity. So it's important to be active. Exercise, for example, even if it's 30 minutes a day, is useful. Any form of exercise in which, and aerobic exercise helps improve headaches. So there are patients with chronic headaches or chronic migraine, and we put them on exercise programs, the headaches improve. Then R is for relaxation. So you need time to relax from stress, because stress is a predictable trigger for headaches, and it also makes headaches worse, makes migraine worse in every and in anyone. So what I say is, it's linked to the next one, and that's a T, the trigger.
The trigger.
Trigger, yes. So every migraine sufferer usually has some form of trigger, something that triggers their headaches. So for some people it's sleep deprivation. For some people it's too much sleep. Each person needs to study themselves and identify what their triggers are and try to avoid them. So that way, that helps headaches to improve.
What are the common triggers for migraines?
That's an important question.
Yeah.
Okay, so it differs for everyone. But for a lot of people, it's insufficient sleep. Some people know that if they wake up too early, then they may have a headache attack. For some other people, it's dehydration. For some other people, it's too much sleep. For some other people, it's stress. For some other people, it's exposure to bright lights. Some people have found out that if they take certain diets, it makes them have headaches. So it differs for it.
For instance, chocolates. I've never understood this. Chocolate can actually be a trigger for migraine. How does that even work?
Right. This is debated amongst headache specialists, actually. So there are those who think that chocolate and some foods or some food sensitivities, so to speak, can play an important role in headaches or inducing headaches or worsening headaches or triggering headaches. Whereas there are those who think that it's not the food or diet per se that triggers the headache, but that just before a migraine attack occurs, like a few days before it, 1 or 2 days before it, there are some changes, both mentally and physically. Such individuals might begin to get tired, might begin to yawn, or have food cravings. That these are behaviors that precede a migraine attack. So such individuals have cravings for chocolate, and that's part of the behavior that occurs before what they call the prodrome of migraine. So that it's not a chocolate itself that induces the headache, but that the individual just has a craving for chocolate as part of the behavioral prodrome to migraine, and therefore they take a lot of chocolate, and then later they start having headaches, and they think it's the chocolate that causes the headache, but rather it's actually a behavioral change that occurs just before the headache. So for me, my stance is in the middle. So, but I don't push so much of diet to my patient, because you don't want to remove enjoyment from life completely. But when you say don't eat that, stop this, stop that, but as much as possible, or you tell people, some people say alcohol makes their migraine worse. So then it's very easy to say stop drinking alcohol, but then in reality, so the point is to make them not, make them still enjoy their life as much as possible, but then bring in some other interventions that can help. So this is my approach. So I don't dwell so much on diet.
All right, doctor, thank you. So from all the lifestyle changes that can be used to put migraine at ease, we come to the big T. What's the treatment for migraines?
All right, when we talk about migraine treatment, like I said, the first thing is lifestyle changes, and we've talked a little bit about the lifestyle issues. Now then we move on to medications. So when lifestyle is not enough, certainly lifestyle changes are very important, but sometimes we may need to combine medications with that. Well, I like to start with lifestyle changes, especially in those in whom I can identify some lifestyle issues that are contributing to their headaches. But when that is not sufficient, then I move into the realm of medications. Now we've got two kinds of medications that we give people with headaches. We've got what we call migraine relievers or acute treatments.
Okay. What are these?
Okay, so these are medications that you take when you have a headache to help stop the headache. So what I tell my patients is, I don't want you having headaches lasting an entire day. That's not acceptable. So I want your headaches to stop within 2 hours. So like I said, that someone with migraine, you can't really stop them from getting headaches. But then when the headaches do happen, you want the headaches to end within 2 hours. So we go looking for the medication that's suitable for each individual that's able to stop their headache within 2 hours. So we'll find 1 or 2 of such, and we'll provide the patient with that so that they have those 2 options of what to use when those headaches occur. Now we have the second category of medications that we call migraine controllers or migraine preventatives. So this group of medications, what they do is to help prevent headaches. I'll give you an example. Now you have a headache right now and you take paracetamol, let's say 2 tablets of paracetamol or Panadol, and it helps you to stop the headache. So it only takes care of the headache you're having now. Does that stop you from having a headache tomorrow?
No, it doesn't.
No, it doesn't. Okay. But there are medications that can potentially reduce your chances of getting another headache tomorrow. So we call those medications preventative medications. So those medications need to be taken very regularly, be it daily, depending on the type, or be it monthly or every 3 months, to help to reduce the chances of getting headaches. So for example, if we start out with, let's say 10 headaches a month, now our target will be to reduce that number by half. So our target will be to say we want to achieve 5 headaches a month, and that would really improve the quality of life. In some people, you get more improvement, perhaps 60% improvement, 70% improvement, but that's the goal of those preventative medications. Someone who starts out having headaches every single day, we want to reduce that to 15 days or less, and that's a big achievement. They can function better and all of that. So that's the second category of medications that we give. But it's not everyone who qualifies for that.
All right.
So the question I ask my patients is, do you think these headaches are frequent enough to warrant you taking a pill every single day? So you weigh the burden of taking pills daily against the burden of your headaches. So if they think, wow, these headaches are just too frequent, they're just too many, that doctor, I don't mind taking a pill every day, then I say, okay, then you qualify for preventative. But as a rule of thumb, we say we use the rule of 5. So if you're having more than 5 headache days in a month, then perhaps you qualify for preventative medication. And if you're having less than that number, you probably don't need it. So you just need your doctor to work on finding you an efficacious medication that can stop the headache within 2 hours when they do occur. So that's the approach to treating migraines. And then we also identify other coexisting problems, because many times you might have migraine patients having depression in the background, having anxiety. This is really very common, having sleep problems and bipolar disorders. So we need to identify these things, epilepsy, and then that also helps us to choose the right medication. Because sometimes we use a stone to kill 2 birds. We choose a preventative medication that would help the headache and at the same time address the underlying coexisting medical problems. Some might have hypertension, for example, diabetes.
Exactly.
So you want to choose medications that would help to target all of this at the same time. And we also look at so many other factors. Someone who's planning to get pregnant, for example, you want to choose a medication that would not be toxic or dangerous to the baby when eventually the person gets pregnant. So we factor in so many things in while deciding treatment.
I have another scenario.
Right.
Once upon a time, I had a friend. So I think this was my first time coming across a migraine.
Right.
She would get the recurrent migraines maybe I'd say 2 or 3 times a month for a couple of days. And she would take relaxation medicines. I cannot tell you the brand names and all, but I'm sure you understand. How helpful are these? And would you recommend somebody to take them for migraines?
Right. Certainly, there are some doctors who do that, like some headache specialists that, when you're having a headache, if the headaches are going on right now and they're very severe, certainly you need to relax. That helps to, make the headache subside. So that could be part of the therapy, because again, there's so many things. It can be medication, it can be relaxation, just lying down somewhere and relaxing as much as you can, breathing exercises,
Mm-hmm.
soft music if you can tolerate it, massage or wherever, even cold packs around the head, putting out all the lights, and then taking the pain medications, or sometimes even relaxing medications can help to resolve an ongoing headache. Yeah, I agree. That can help.
All right. Thank you, doctor. Finally,
Thank you.
what are the risk factors for migraines?
Well, risk factors, I would say, if you've got a family history of migraine, then your chances are high that you may have, or higher than those of any other person or other people around, of having migraine. If your dad or mom has got migraine, your chances are higher than those of other people. And then lifestyle issues. So, of course, the greatest risk I would say is genetic.
Mm-hmm.
The greatest risk is inherent. Say someone is born with those set of genes, then it might manifest, but may not always manifest. It depends on environmental factors as well. Imagine you having a very fertile land somewhere, yet it's not raining there, so you may not have grasses growing there. So someone might have those genes, but then because they've been very healthy all their lives, they sleep well, they don't stress so much, they may not manifest a migraine susceptibility. So, but then the greatest risk factor, I would say, is genetics.
All right. Well, thank you, doctor.
Thank you.
This deep dive has been very, very enlightening. To our listeners and those who are watching us, you can visit King's Neurosciences Center, where you'll be able to meet Dr. John and his colleagues for migraines and headaches clinics. Until next time, this is the Wellness Dive, King's podcast with Lucky. See you again soon.